Medical emergencies are one of these things that you really hope you're never going to have to deal with. However, we have to be able to deal with them if, and unfortunately when, they do happen. It is very unlikely that you're going to get through the entirety of your dental career and not experience some kind of medical emergency. Because we don't deal with them often, and because of the nature of it being an emergency, it can be very easy to panic, to become flustered, and therefore not be able to deal with the situation properly. So when we think medical emergency, we're often go straight in our mind to like worst case scenario CPR. But in the ideal world, you're going to manage that emergency early, recognise it early, manage it early, and manage it to the extent where it never gets to that point of an unresponsive patient. So one of the things we need to do when we're managing these situations is have a really set, rigid way of doing things. And that's what I want to talk about in this presentation. Your assessment process of the patient needs to be exactly the same. Whether that is a patient who has sat up to have a rinse after treatment and said, oh, do you know what? I'm not feeling great. Right down to a completely collapsed on the floor, unresponsive patient. If you always follow the same rigid process, it's easy to remember. So you're not going to find yourself in that situation going, oh, what do I do? What do I do? No, I'm going to go through this step-by-step process that will lead me to what's wrong with this person and what I'm going to do about it. The other thing that you need to be able to do is to manage that whole situation, not just the patient who's unwell, but also everybody else who's in the vicinity. So that could be colleagues, it could be members of the public, depending on where it's happened. And again, that cool, calm exterior is important in that situation. If you've ever had any experience with paramedics, you'll see they often appear to be the calmest people, like nothing bothers them. They'll walk into what appears to be a real catastrophic emergency situation, and they'll spend the first 1 or 2 minutes appearing to be doing nothing, but what they're actually doing is they're assessing the situation. So I'm going to take you through the assessment process, or the assessment tool that we're going to advise you to use. We've already looked at it a little bit earlier in your time as a student when you've been doing particularly basic life support, but we're going to just delve into it in a bit more detail today. But I hope that you can understand why it is that we're being so rigid about this is the way you must do this. And it's for those times of blind panic. You've got this safety net. I don't need to panic. I'm just going to follow this process. So having something to help you remember your assessment process is really important because of this stressful environment that we're in. So we use acronyms for that. So, you know, where you've got letters that stand the first letter of each word of the tool. So we've used these before when we've talked about medical emergencies. And what we've used in the past was what we often call doctors ABC. So DRS ABC. And that stood for dangers. So protect you and the people around you. Look out for any dangers that are in the area and remove them before you start trying to look after the patient. Super important because otherwise you're potentially going to end up with more patients and more emergencies to deal with. S stood for response. So if you shout at the patient, are they responding to you? We talk about shaking them, shouting in their ear, maybe causing a wee bit of pain to see if they respond to you that way. And then S stands for shout, as in shout for help. Now, when you've in the past been dealing with particularly basic life support, that shout for help was oh my goodness, I need an ambulance, like phone the ambulance, get me all the emergency kit, and so on and so forth. And like I just said, we are ideally hoping to assess and manage this so early that we're not going to need that kind of assistance. But there are still times when we would need emergency services and medical kit. And regardless of what's going on, it's always worth having at least one other person there with you to help. So shout for help is still relevant. Then we went on to A, B, and C, which was our airway, breathing, and circulation. This algorithm, or DRS ABC, is absolutely fine for the very, very basic assessment that you've looked at previously, particularly when you've been doing BLS. But now that we're moving to become more qualified, more competent, more educated clinicians, we need to take this up a level and go for a slightly more sophisticated approach that allows us to assess our patients a little bit better. So let's swap that out, and we're going to keep the DRS, okay? That's always worth having. We're just going to park that up the top. DRS, danger, response, and get some help. But now we're going to look at the ABC part, and we're actually going to turn this into A, B, C, and D and E. So the D and the E we've added here. So A continues to be airway, B for breathing, C for circulation, D stands for disability. And what that's referring to is how conscious a patient is. If there's anything that's causing them to be less conscious than you would consider a fully alert patient to be. And then E stands for exposure. And what that means is when you expose the patient's body, so when you remove their clothes, is there anything there that you can see that's likely to be part of the problem? So when we've used certainly ABC before, we've kind of done this with the mindset of somebody who's unconscious. We've been thinking about this patient who's lying on the floor, who can't speak to us, and is completely out cold, that we're probably thinking we're going to need to do basic life support for, so CPR. Now we're thinking about this in the medical emergency context. You could do all these steps. The patient could have a perfectly clear open airway, be breathing fine, their circulation be fine, no obvious disability, and nothing of concern in terms of exposure, but still be ill. Also, the patient could have breathing, like they are breathing, but it's not ideal. Maybe they've got quite a wheeze, or their circulation, maybe the pulse is too high rather than not there, for example. So we're going to go through each of these with a bit more detail now and think about what it is that we're aiming for and what it is that we're actually assessing and what we would expect to see. So first of all, airway then. This is an image you should be pretty familiar with. This is our head tilt chin lift that we've spoken about previously when you've done CPR. And this is absolutely appropriate for your patient who is unconscious. You can see from this image that we've got some closed eyes here. So that patient is not responding. And what happens when a patient's head is in a neutral or particularly a chin down position, which could easily happen if a patient became unresponsive in the dental chair, if you think about it, their head could slump forward. The tongue slips back and the soft palate tends to come down and meet it. So they can't get anything through air through their mouth because there's a join between the palate, soft palate and the tongue, or a connection, sorry. And they're actually not getting anything in through their nose either, because this posterior third of the tongue is blocking that airway. So the patient in this position cannot breathe because of their airway. It's not that they're not having a breathing reflex, it's that when they're trying, nothing's going in. This is often what people talk about when they, in inverted commas, say someone swallowed their tongue. You cannot swallow your tongue. It's physically not a thing. Your tongue is attached, as you guys know, at the floor of the mouth. So you can't swallow it. But you can be in a position where your tongue is making it difficult for you to breathe. So the head tilt chin lift is very important from that perspective. And it could easily be the case that your patient is unresponsive and is becoming hypoxic, so their oxygen saturation is decreasing because they can't get any air in, and that's why they've become unresponsive. All that patient needs is for you to open that airway so they can physically take a couple of breaths, and all of a sudden things will start to get an awful lot better. This could also be a patient who's become unresponsive for many other reasons, but if you leave them with an airway that is not patent, so not open, they're going to end up in a cardiac arrest situation because they're not being able to take in any oxygen, therefore the heart muscle can't function, therefore it will stop or certainly go into fibrillation. So airway is absolutely our first point to think about. The other thing we need to think about in the airway is there something stuck in their airway? Has something got down here into their trachea? So are they choking? Again, entirely possible with a patient in our dental chair. We put a lot of things in their mouth. Perhaps we're talking about a cotton wool roll and maybe they've inhaled it. So in those situations, their airway is not patent, but not because of anything that you could a head tilt chin lift would help for. So in that situation, we would go down the route of dealing with it as a choke, which we're going to look at a later stage. Maybe there's just something stuck in their mouth that, whilst it's not blocking the airway, could become a problem at a later stage if that patient becomes unresponsive. So again, we're halfway through a dental procedure. Maybe there's some rubber dam, maybe there's a matrix band, maybe there's a loose denture. Those things need to come out. Thinking of dentures, however, particularly if your patient's completely unresponsive, if the denture fits well, leave it in. And when I say fits well, if you put your fingers on it to take it out and it doesn't immediately move, just leave it there. Because particularly with full dentures, it can be hard to get a good seal with a mask if that patient requires you to breathe for them. But anything that's loose, get rid of it. It might not be a problem there and then. Maybe they're responsive at that moment in time, but let's think about preventing any further risks. If a patient can talk to you, then their airway is open. They might be saying to you, oh, I'm finding it hard to breathe, or they might have a bit of a wheeze. And that's certainly something to note, because that could be an indicator of what the problem is. But their airway is open at that moment in time. Also bear in mind that an airway can be blocked not by a foreign body, but it could be blocked by swelling. And the classic example of that obviously would be some kind of allergy. But actually asthma kind of fits into that category as well. If the airway, if the patient's struggling to breathe, they've got a strong wheeze and they're really not able to talk to you properly, then that would suggest that there's an inflammatory swelling process going on. That needs to be dealt with in order to fix the airway. Let's not bother thinking about anything else. If the airway's the problem, and we're still at A, we have to think about how we can open that airway, and that may be about administering emergency drugs, which again we'll talk about later. But if a patient can hold a conversation with you, their airway is patent. Moving on to breathing then. What we are trying to assess with any patient who tells us they're not well is, are they breathing normally? Not just, are they breathing? A patient who is not breathing at all will not be responsive and needs resuscitation. Let's hope you very rarely, if ever, have to deal with that situation. But you will come across a patient who has what we might call laboured breathing. So it's they're having to put a lot of effort into it. Laboured. So they're using accessory muscles. Their shoulders are going up and down as they're breathing. Their stomach's really working hard in and out. They, every time they take a breath in or a breath out, they're really wheezing. So a wheeze of any kind. Normal breathing should be somewhere between, let me just get back to a different colour, somewhere between 12 and 20 breaths per minute. So every few seconds, maybe every 5 seconds at least, breathing. And also it should be steady. So there is always breathing activity. You're breathing in, you're breathing out. There may be a 1 second pause at either end of that, but there shouldn't be a breath in, a breath out, and then a 10 seconds where you're doing nothing. That's not normal breathing. You need to use lots of different senses when it comes to checking for somebody's breathing, checking to see if the breathing is normal. Okay, you're going to be looking at them. Let's presume this is a alert patient. Okay, they're conscious, they're sat in the dental chair. I'm going to watch as they're breathing to see if they're using these accessory muscles I just mentioned. I'm going to listen to see if I can hear that wheeze, or perhaps even something that sounds like a snore. And then I'm also going to feel. Now, in the situation where a patient is collapsed on the floor, you would tend to do that by putting your hand on their chest. But actually, the best thing to do with somebody who's sat upright and somebody who's conscious is to put your hand between their shoulder blades and rest your hand there. And then you will feel how much effort they're having to put into that breath. And it also can generally be just quite a comforting thing for the patient. So you're going to stand side on so you can still see everything that's going on, but just pop your hand just between their shoulder blades and just take a few seconds, up to around about 10 seconds to check for that. And that will give you an indication of, are they breathing normally? Next thing then is circulation. This is how well the blood is circulating around their body. Airway and breathing come first, because there's no point in concerning ourselves with whether the blood is circulating if the person is not taking in any oxygen or getting rid of the waste gases. So we're confident that the airway is the best it can be. Their breathing is maybe not ideal, but it's enough. Now we're going to think about circulation. The classic way to check somebody's circulation out with a hospital setting, of course, would be to check for a pulse, a peripheral pulse. So somebody's radial pulse in their wrist or somebody's carotid pulse in their neck. That's quite a personal thing as to whether you feel comfortable to do that. I have dealt with medical emergencies, and I can say absolutely with certain truth that I could not have told you a patient's pulse at the time, because the only pulse I would feel would be my own. Your heart is going to be pounding when you do this. Let's not try feeling for pulse. So for most people, I would rule out checking a radial pulse. Another thing slightly easier is what we call capillary refill time. So we check cap refill by checking the patient's fingernail. So you put pressure on a fingernail for a few seconds, and when you take, and you'll see the nail blanch as you do that, when you relieve the pressure, the colour should go back to normal within 1-2 seconds. If it's taking longer than that, that means that the pressure in the periphery is so low that it's not filling back up what you've just squeezed out by squeezing the end of the finger, and therefore their circulation is poor. So capillary refill is one way to check. The other thing just to generally check is their colour, particularly if we're talking about a real extreme issue with circulation here. Patients who are not circulating blood properly are hypoxic, so they've not got enough oxygen. So they will look grey. They're not going to have any flushing to their cheeks or anything like that. They're going to look very pale, very grey, and possibly a bit bluey purpley around the lips. Their extremities, so their fingers and their toes, may also be a bit bluey purpley colour. Despite being very pale and probably cold to touch, for again the same reasons because of low peripheral pressure, they will, however, be sweaty. So pale and cold, but sweaty. All these things are a sign that we have an issue with our circulation. So I've already said quite a couple, I think, a few things there that will help you determine if the patient's circulation is okay without doing a pulse. However, there is something that we have available to us in our emergency kit which will 100% give you a pulse rate. It'll tell you how many beats per minute your patient has, and that is a pulse oximeter. If you have any concerns that your patient is unwell, put a pulse oximeter on them. It is completely non-invasive. It doesn't matter, just put it on any finger, doesn't matter, and it will straight away tell you two things. It's a little bit hard to see on this, but it's got two numbers. There's the one on, sorry, that's a terrible arrow, but there's one on the left and there's one on the right. So the one on the left says 98 and the one on the right, I think, says 62. So, and it will have BPM written after it. 62 BPM is your pulse rate. That person has, their heart is beating 62 beats per minute. That would be great, perfectly normal. 60 to 80 BPM is your normal range. Let's just add that there. So our normal range for your heartbeat is 60 to 80 beats per minute. So just put your pulse oximeter on your patient and that will straight away tell you what their heart's doing beats wise. It won't tell you about rhythm. It will just count how many beats there are in a minute within a few seconds. Now the other number is your oxygen saturation. 98, it's a percentage, so that's 98%. That would be fine. But it's a useful figure to give us in terms of understanding the patient's airway and breathing as well. If that oxygen saturation is above 94, 96%, their airway is fine and they're breathing okay. They're getting enough oxygen in. If it falls below, for most people, 96%, then we'd be a bit concerned and would be wanting to supplement that. So that would suggest that there is an issue with the oxygen getting in. So I would put a pulse oximeter on every patient who says to you, I'm not feeling great, or looks a bit poorly. What's the harm? Really useful information. Moving on then to our new categories that we haven't really spoken about before, are disability and exposure. So like I said at the start, disability relates to how alert your patient is. And to define that, we use what we call AVPU. In the medical field, they would also use what's called the Glasgow Coma Scale. That's well beyond our capacity. We just, yeah, that's a whole scale that we don't need to know. But AVPU is something that we can easily do. So AVPU stands for alert, voice, pain, or unresponsive. So this kind of comes back to that R right at the start, so our DRS doctors. The R is your response, and this is the point at which you can actually make an assessment of the disability. So that patient may be talking to you fine. They've told you they feel unwell. That patient is alert. Anything after that, so anything where the patient isn't able to talk to you, or they're talking to you but it's absolutely not making any sense, then we need to think about the next three options. So voice means that although the patient is not completely responsive and they're not completely alert, and they're not making a lot of sense, they do respond when you speak to them or shout at them. So say you had your patient who'd all of a sudden got quite confused, maybe they were trying to get up out the chair or whatever, and you said to them, "Mrs. Smith, are you feeling okay? Are you feeling all right?" And at that point, nothing changed, like they still were behaving in exactly the same way before, so they haven't actually responded to you talking to them, then that patient wouldn't be responsive to voice. What you're looking for a voice response is some kind of indication that they've heard you and understood you. So, "Mrs. Smith, are you feeling okay?" And they look at you, and maybe they're still not making sense, but that they are responding, they're acknowledging that you're there. That would be a voice response. Another sort of possibly more common reaction that would be voice disability would be a patient who has got their eyes closed and therefore they're not alert, but when you say, "Hello, can you hear me?" you get a so it's a response of some kind, not an alert one, but they are voice responsive. Pain means that the patient will only respond if you stimulate the pain response. So that patient that's lying on the ground that's not responsive, you shout at them, "Are you okay? Are you okay?" and you get nothing. But when you give them a pinch somewhere uncomfortable, so earlobe, back of the arm, they try and pull that body part away from you. The other thing is a sternum rub. So you rub quite firmly across their sternum, so their chest plate, and again, they should recoil. Your pain response is the last thing to go. You can be pretty out of it, but you can still protect yourself from pain. If you do all those things, you've spoken to them, you've tried to provoke some pain, and you get nothing from that patient, then they are unresponsive. So when we're doing this assessment, we're going to make a note of where the person is on this AVPU scale, and bearing in mind that it could change. The patient may start alert and end up completely unresponsive. We would hope not, because that's why we're dealing with the emergency, but it is a possibility. So this is something that you have to be constantly reassessing. Do not be fooled. Just because a patient is alert does not mean they are well. A patient having an asthma attack, for example, will be very alert initially. They are not well. And if you continue to allow the asthma attack to happen, or if it doesn't respond to the treatments, they will become unresponsive eventually. So just because they're alert doesn't mean everything's fine. The last thing to think about is exposure. There's not many occasions where it would be particularly relevant for us, but there are a couple of things. So this is when you are looking at their body, So you need to remove clothes and look at their body and see what's going on, and that might tell you something. So this child here obviously has a significant rash. I would suspect what we're looking at there is a child with penicillin allergy. So allergy is a good example of where exposure might be important. Perhaps your patient is presenting with some kind of anaphylaxis. You're going to manage that, but you also try and need to work out what's caused it, because otherwise it could be continuing to provoke it. So maybe let's get their t-shirt off, and perhaps they've been stung by a bee. But also they might have a significant rash in the area where the allergy has started. An allergic reaction tends to spread down the neck as well. So if they're wearing like a high neck something or a jacket that's zipped right up, get that undone and you can see if the rash is extending down there. The other thing you might see when you expose somebody's body is some kind of injury. Perhaps they're bleeding heavily. Maybe they've cut themselves and it wasn't particularly obvious. Maybe it's an old injury that they haven't, maybe happened a couple of hours ago and they've been trying to ignore it. Maybe that person, for example, had a car accident earlier in the day and they kind of just got up and walked away. Your classic guy, for example, he's like, oh, I'm embarrassed, I'm just going to walk away from that situation, I'll be fine. But actually they're not feeling very well when they come to see you, and when you take their t-shirt off they've got a massive great big bruise and swelling in their abdominal area. That would suggest that person's bleeding internally. So injury or bleeding, anything like that could potentially be an indication as to what the problem is. And all these things, whilst it might not be something that we could deal with in the dental surgery, will be very relevant in our assessment of the patient and then handing that patient over to emergency services or the hospital or whoever it is that's dealing with it in that situation. Whilst exposure is relating to assessment and working out what's wrong with the patient, there is a couple of other things you want to think about whilst you've got the word exposure in your mind. First of all, let's think about warmth. Is the issue actually that they're too exposed? Is this patient, the word has gone straight out of my head, were they too cold? Hypothermic, there we go. Is the patient hypothermic? Again, it's kind of unlikely that that would happen in the dental surgery, but it is possible. Maybe this is an elderly person who's had to walk quite a long way in the middle of winter to come to you. Maybe they've come from a cold house in the first place. This is something that we're seeing with the cost of living crisis. So perhaps the issue that's causing them to be unwell is that they are too cold. So do we need to warm them up? Similarly, if you have removed clothing in order to assess the patient, don't let them get cold. Get something over them afterwards, get the blanket over them. So their body temperature is relevant in terms of exposure. And the other thing is just think about that person's dignity as well. Particularly if this is in a public area, most faints or generally a faint, but most keeling over, shall we say, happens actually in the waiting room, because the patient is either very anxious about going in or they've come out and they're not feeling great afterwards and they faint there. So if we're going to be exposing somebody's body in order to treat them, let's not do it with a massive crowd around us. Let's get some kind of screen up. Like, these are the things you want to be asking the people around you to help with. So you're the person who's managing the situation because you came across the patient, but the people that come and help, these are the people that you can say, can you get everybody else out of this waiting room, please? Can you bring me a blanket? Perhaps there's some kind of screen that can be put up that would just give that person a bit of dignity. Because hopefully that person is going to come round, or maybe they're even fully alert anyway. The last thing they need to be doing is worrying about people around them as well. So just to go back to our algorithm that we're going to be using from now on, we're sticking with our DRR, so our danger, response, and get some help. But now we're looking at this 5-step process of airway, breathing, circulation, disability, and exposure. It's an assessment process in that order, but we're always going to remember that, first of all, this is dynamic and it could change within seconds or minutes. And secondly, remember that just because one of these things might be fine, they might have a perfectly open airway or they might have no disability, that does not mean they are well. So over the rest of the resources that we've got in for this week, we're going to look at specific medical emergencies, and we're going to be applying this algorithm, this tool to assess our patient to all those different specific situations.